All right. I think I got it where I want it. All right. Well, good afternoon. My name is Dr. Stacy Obai, and I'll be talking about operating as a behavioral health consultant in primary care. I will say we'll definitely have a good amount of time for Q&A towards the end of this hour. And so if you do have questions about the certificate course, I'm also happy to answer those questions too as after we finish today's talk. So just throwing that out there. Happy to answer those questions as well as any questions that come up today during today's talk. I do many different things in my professional roles there, but today we'll be talking about something that is very, very important to me, which is how to operate as a BHC in primary care. So these are the objectives for this afternoon. Of course, I can't talk about being a BHC without talking about describing primary care, so we'll do that first. We'll talk about the PCBH model because the BHC is connected to this specific model of integrated care, and so I'll talk about that. And then, of course, talking about how the BHC functions in primary care. So if you can in the chat box, if you can place your name, sometimes Zoom, we have different codes that are listed as our names. It's not actually our full names. And so if you could type your name, your organization, if you work in primary care, what's your role in primary care? If you don't work in primary care, let us know where you're working, which is great and what you do there. If you want to share an email address, you're welcome to do that. You don't have to. Just to give us a chance to know who's here, but also to let people in the room know who may be in their backyard when it comes to connecting and networking after today's talk. So please take a few moments to give us a little information about who you are in the chat box. And then I also want this to be as interactive as possible. So I'll have questions for you during this talk for you to place your responses in the chat box. But also if you have questions as we go, you don't have to wait until the very, very end of the talk. If you want to throw it in the chat box, I can pause and answer it, or I might just collect them and address them in the Q&A so I don't miss anything. So thank you. Thanks to those who are throwing what you do in the chat box. I really appreciate that. All right, so just some general terms that are quite important for a talk like this. Based on what I'm seeing in the chat box, you all know what these terms are. PCP means primary care provider. That could be a family physician, pediatrician, internist, even an OBGYN, NP, PA, any of those specialties could be classified as PCP. And then for behavioral health consultant, that could be any of the disciplines Alina mentioned a little bit ago. So you could be an LMFT, an LPC, an LCSW, or a licensed psychologist, an LP. So any of those behavioral health disciplines could fit into the role of a BHC, and we'll talk about that momentarily. Just taking a look to see. Okay, yeah, there's folks all over. This is great. Working in outpatient primary care. Awesome. Well, this is great. Thank you all for being here. Folks are from all over, which is pretty exciting. So, first and foremost, one of the things that I always like to start off with when talking about primary care is the high quality primary care white paper that came out in 2021 by the National Academy of Medicine. It's been a few years now. If you haven't had a chance to take a look at it, it's fantastic, where they essentially redefined what high quality primary care should look like, updated it from the 1996 definition. If you don't have all the time to read the 150-page plus document, there is a 2-page white paper that they did that's fantastic. That I promise will take less than 5 minutes to look over it. But they present this new definition of high quality primary care, which I've bolded some of the pieces here to point out to you that I really like. Care that addresses the whole person, care that's, of course, integrated, accessible, that's equitable. So that's something that was not in the initial definition, and care by interprofessional teams. So this new definition really took into account behavioral health as part of the interprofessional care team. They also talked about other calls to action, which are equally important. But I really love the fact that they dedicated a whole chapter to behavioral health integration in primary care. And one way to do that is through the primary care behavioral health consultation model. So I'll focus on that for today. Another aspect of primary care that is incredibly important is the work of Barbara Starfield. If you don't know who she is, now you can say you know who she is, but her work was seminal in just giving the definition of what primary care is. She was a pediatrician by training and essentially discussed these 4 C's of primary care practice. And so the first one being the first contact. We are the closest to the community in primary care. And so hopefully we are the first contact for patients who are coming into the healthcare system. Then we have comprehensiveness, which again, if we are living up to the high quality primary care definition, then we would definitely be fully comprehensive, where someone can come to primary care and really get the majority of their healthcare needs met, whether it's physical health, behavioral health, it could be spiritual health, social health, financial, whatever that may be. They can get access to the services they need under one roof. Then you have continuity. And so really being able to have that personal relationship with your healthcare team, not just your PCP, but also it could be your BHC, could be your clinical pharmacist, it could be your dietitian, but having that continuity of care across the time that the person is part of that practice. And then coordinating care, whether it's within your health system, whether it's between you and specialty care, but really coordinating care effectively. And so again, the way that your role as a BHC was meant to be really lives up to what Dr. Starfield talked about, primary care really having these 4 C's to define how we function in primary care. And so to transition and talk about the behavioral health elements of primary care and behavioral health it's you really can't tease those pieces apart because it's just inherent in the work that we do in primary care. This is where everyone comes for these services. 80% of folks with the behavioral health condition will show up in our offices. Over half of behavioral health issues are already addressed in primary care. So why not go where the people are already showing up? Again, if we're that first contact, if we're offering comprehensive care, continuity, and we're coordinating care, behavioral health is an essential piece of that. So again, really showing the importance and why the BHC is such an integral part of the primary care team. So question break. This is where you can type in the chat box your response here, just to see if you're paying attention, which I'm sure each and every one of you were paying attention. So this is true or false. So you can put T or F in the chat box. Most people who seek help for mental health issues go to a mental health clinic and not their PCP. True or false? What do you think? Thank you. Thank you for that. That is false. They come see most of you. Most of you are already in primary care, so they're coming to see us. So fantastic. So let's talk about integrated care. There's lots of ways to do this. I'm just going to pull up lots of different models that you may or may not have heard of on the screen, and they're all incredibly effective depending on what the goal of the clinic or health system is. Some clinics have a combination of different ways to integrate care. You could be doing COCM, the collaborative care model, where you have your consulting psychiatrist and your care manager. You could have a chronic care model approach where maybe your primary care clinic has a high amount of individuals with type 2 diabetes that have uncontrolled type 2 diabetes. So you wraparound services for this one specific high needs condition in your practice. So that's an example of chronic care. I've seen it done with hypertension. I've seen it done with chronic pain. So you could do it with many different conditions that show up pretty often in primary care that you feel your practice doesn't have a good grip or handle on that and managing that effectively. Then you have co-location, where you have your more traditional psychotherapy happening side by side. Could be in the same building, could be maybe on different floors, could be in the same clinic but different parts of the clinic. Not incredibly integrated per se, but this is a way of doing care. And then, of course, what we'll talk about is the PCBH model. Sometimes we call this integrated primary care, IPC. We use those terms interchangeably. So again, these are all different ways that you could do this, but the BHC is an element of the PCBH model. So that's what I'll focus on for today. When we're operating at the highest level of integration here, if you think about SAMHSA HRSA's levels of integration, typically the PCBH model, if done in a high fidelity way, there's definitely ways to do it in a not high fidelity way, but if you're doing it the way it's intended to be practiced, you're typically at that level 5, level 6, which is the practice change piece. How the different individuals on your care team should be practicing differently. If things aren't really changing, if your MAs aren't changing how they practice, if your PCPs, if your behavioral health team members aren't changing how they practice, it's a good indication that you may not be at the level 5, level 6. But if BHCs are seeing patients in exam rooms, they're not in these offices down the hallway, down in the basement and other parts of the clinic that make it feel very separate. If your MAs are, offering BHC services after they do vitals for a patient who's screened positive for tobacco cessation, and they're connecting the patient to the BHC. If those types of things are happening on a daily basis, you're most likely probably in this level 5, level 6, fully integrated level of care. All right, I have another question. For you all. So it's multiple choice this time. Interdisciplinary teams working to meet the needs of the general population in primary care best describes the care provided at which level of integration. So you have your full integration, your level 5, level 6, the higher level, collaborative co-location. C is collaboration at a distance, and D is siloed specialty care. So what do you think? Care that's meeting the needs of the entire population, not just a subset of the clinic population. What would you guess that would be? All right. I love it. This is like a group of stellar BHCs here. All right, you're absolutely right. It is A. So now let's talk about the PCBH model, because that is really what ties the BHC to primary care. And so when we use the term behavioral health, many times people might function on one side of the umbrella, thinking about substance use related conditions and your more traditional mental health conditions. But when we say behavioral health, we're really meaning that plus everything else, the physical health conditions, health behavior change, diet, physical activity, management of chronic health conditions, medication adherence. All of these things fall under the behavioral health umbrella. And so this table here, I think, gives a short list of the things that fall under the scope of what a BHC could do in primary care. There's so many more things a BHC could do, but typically if someone asked me, well, where would I start if they were a new BHC in primary care? This is what I would show them is here's a place where you could start, but depending on your clinic, depending on your patient population, it could look a little different. And so, of course, we're up at the top. We do the behavioral health conditions, substance use things, but then we also help with stress-linked conditions like insomnia, chronic pain, migraine, tension headaches. We also help with health behavior change for things like high blood pressure, diabetes, COPD, asthma, obesity. So the list goes on of what the BHC could offer. And so if you are wondering, especially if you're in a place or you're watching this and you're thinking of starting a PCBH service and you're thinking what are the things that the BHC could help with, this is a starting point for you and your team and your system to think about the different ways the BHCs could support your primary care team. So of course, this just goes to show why this is so important. These are common, these are expensive, they're disabling, and who would have thought if you treat it, they get better. People get better over time. And so again, um, really showing the importance and benefit of having a strong behavioral health workforce who are part of the primary care team, primary care workforce. And patients prefer it. My colleagues and I a few years ago looked at patient satisfaction with PCBH services. We compared an underserved population similar to an FQHC population to an Air Force population that has more access to both primary care and specialty care services. And both groups preferred care in primary care, specifically at the point of care. They're already there seeing someone in the clinic, whether it's a PCP or a pharmacist or someone else on the team. They would like those services preferably on the same day. So again, if you're thinking about making a pitch to your leadership about either starting a PCBH service or expanding it, if you are the lone BHC or there's just a few of you and you're like, there's so much more we could do if we had the bandwidth, these are the types of things I would encourage you to share with your leadership to show that it's not just it makes sense, but also patients and families prefer it. Um, other ways of care. So what does this look like as a BHC? Let's talk about that. So again, your role as a BHC could look like a lot of different things. It could be one-on-one visits if that's what's needed. It could be helping with the screening process. If your health system, like many, do universal and secondary screenings that are done during the triage process, you could help design those to be effective and evidence informed. Maybe you have a population that likes classes or workshops or group visits. You could facilitate those with another primary care team member, whether it's a PCP, a dietitian, a pharmacist, all of the above, depending on your clinic needs. Down at the bottom are just some ratios there to help think about your clinic needs and how to be effective. So if you're one BHC in a sea of 13 or 14 full-time FTE physicians, this lets you know, okay, we need some more people power on our team to support our clinic the way it's intended to be supported. And let's talk about the BHC a little bit more. So who is the BHC? What types of things are they doing? First and foremost, they understand the context of primary care. That's why I wanted to start out talking about high quality primary care and the 4 C's of primary care. Because once you really understand that, it really helps you understand how you fit in the realm of primary care to really see yourself as a primary care team member rather than I'm a behavioral health person in primary care, really seeing yourself as, no, I'm a primary care clinician. I'm part of the team here. And so that's why I really like to start there to help BHCs understand the primary care context. These individuals understand focused, targeted assessment and an intervention for primary care. I put a few examples here of the particularly two ways we interview in primary care, whether it's through the contextual interview or functional assessment. However, you work, these are the two ways that BHCs should be employing interviews in primary care. Number two, familiar with the primary care way of seeing patients. Again, that just goes back to understanding the fast-paced nature of primary care, understanding your role as a consultant and what does that mean versus other roles that behavioral health individuals can play in the primary care setting. Number three, you partner with the panel of patients rather than kind of sitting back waiting for same-day visits or warm handoffs. That's a part of what you do, but you might have scheduled consults. You might also be scrubbing or combing through the main schedule of the day to see who is coming in, to see who could I potentially consult with today. So you're very, very active part of the primary care team. And then I always say if 1 through 3 happen consistently and happen well, 4 happens naturally, where you kind of relieve the pressure off of your PCP colleagues' schedules. So the care that the patients receive is much more comprehensive and hopefully effective. Another way to think about your role as a BHC is Robinson and Ryder talk about the GATHER acronym. If you've been a BHC for some time, you've probably heard of this. Hopefully you're using this as a basis for maybe training your other BHCs in your clinic if you're in a leadership role. But the GATHER acronym stands for being a generalist, so seeing all things that come into the clinic. If you're in family medicine like myself, making sure that you are trained to treat kiddos, adolescents, adults, and older adults, rather than having a BHC that says, oh, I only see adults. It's like, well, then why are you in family medicine then? Go to internal medicine. So really making sure that your training fits the primary care specialty that you are in. So that's the generalist piece. Then you, of course, are accessible. It should be very easy to find you. You hopefully are sitting in the bullpen or the area where the PCPs and the nursing team are sitting. You're sitting right out there with them. People shouldn't have to look to find you. Of course, if you're in an exam room, that's different. But it should be easy to find you, especially with technology. Things like, I know some teams use Microsoft Teams to talk to one another, to find the BHC for a warm handoff. If you use Epic, there's the Epic chat where you can use the chat feature to communicate with one another. So everyone's easily accessible. You're team-based, you're a team player, you understand the dynamics of team-based care and the importance of leveraging your team members well. So you not only receive consults from your colleagues, you also refer to your colleagues. You might refer to the pharmacist. You might refer to the dietitian. You might refer back to the PCP if a patient is here to see you, but they have they need to see a PCP. You could help the patient schedule a same-day visit for a PCP that day. So that team-based piece is really important. You're highly productive. We're typically seeing anywhere from 8 to 14 patients a day. Because our visits are similar to the care structure, if you see at the bottom of your primary care colleagues, the 15 to 30-minute visits. You're an educator, so this could be formal education during your team meetings where you're giving a mini didactic on different topics at each meeting. It could be more informal where you're just having a discussion in the bullpen about questions related to motivational interviewing, or a PCPK may ask you a question, how do I know the difference between MDD and bipolar disorder? What questions should I ask the patient to differentiate that? You could coach them through that, just like they might coach you through the different stages of chronic kidney disease helping the patient with that. So education goes both ways between you and your team members. And then your routine, your regular part of care. Any patient who was part of the primary care practice should have equal access to see you. It's not just for patients who fit into this program or fit into this category per se, but if this is their primary care home, they could essentially walk up to the front desk and ask to see a BHC, and they'd be able to see you that day. So again, the care structure similar to the PCPs, and really that consultation approach, that consultation model where it's a shared patient between you and the other primary care team members within your clinic, where you're giving feedback to your primary care team to support them in the care of their patient, in addition to the patient getting care from you. Of course, I have another question. I can't keep going without questions here. I think this is the last question, I assure you. This is the last question. Another multiple choice question here. Which of the following is not a typical way for a BHC to be used in primary care? So you have A, providing traditional psychotherapy for mental health issues. B, focusing on patient functioning. C, help involve patients in their own care. And D, ensure social factors are considered in treatment planning. So what do people think? I love it. This is a great group. I want you all to show up every time we do this. Yes, the answer is A. You all are fantastic. Again, thinking about the traditional role of the BHC, we're there to be consultants. Again, we are functioning as primary care providers. There are some health systems that the behavioral health clinician has multiple hats, where half their time is traditional psychotherapy and half their time is a BHC. Depending on where you are, you may have a setup like that, but traditionally in the PCBH model, the BHC is not providing more traditional 50-minute traditional psychotherapy visits. This chart is super tiny probably, but you'll get a copy of these slides. But I like to show it just because it gives a nice juxtaposition of some of the differences between primary care work, primary care behavioral health work, and specialty mental health work, just to see some of the differences there. And so I always like to include that here in the slide deck for those who want additional information about some of those differences. These next two slides are really short videos of how a PCP may introduce a BHC. This is something that if you're not giving your PCPs ongoing coaching on how they introduce PCBH services, please do that. We do it on an ongoing basis a couple of times a year. Especially if you have new PCPs coming in, that should be hopefully part of their onboarding process, is how do you introduce the BHC? Words definitely matter. I think one thing COVID did well, among some other things, if you want to think about it that way, is put at least in the limelight the importance of getting behavioral health access. That definitely blew up after COVID, and so making sure that's being explained really well to your patients is of importance. But even with that happening, there's still a lot of stigma. Even with the help of COVID trying to normalize access to behavioral health services, there's still a lot of stigma. So how your PCPs introduce it, it does matter. So I'm going to show you one example of how a PCP introduces the BHC to the patient.
So Jesse, I'd actually like to have another team member come in and help us today. They're our behavioral health provider. They work with the physical, mental, and social health, things like exercise, diabetes, stress management. So I'd like to grab them and actually have them work with us today.
Sounds good.
All right, so super short, really brief. We always tell our PCPs, just give the intro, let the BHC come in and do their thing and explain it to the patient, but that's a way to do it. There are some scripts that are out there that you can give some coaching to your, not only your PCPs, but anybody, your nursing staff. Because again, MAs and your LVNs and RNs should also be introducing the BHC to your patients. If you have a PharmD, if you have a dietitian, there's lots of mini scripts out there that you can give coaching to your team members on how to do that. And then you have, of course, your BHC introducing services. I'm going to skip this video for today since a lot of you in the room are BHCs and hopefully you've done this already. This is a sample patient flow. So again, when introducing a PCBH service to a new clinic or a clinic in your system, thinking about adding a BHC that has not been there before, this is something that we always like to do during the introductory parts of getting a clinic ready and onboarded to have a BHC, is kind of walking them through the flow, patient flow of what this looks like. And so typically the BHC goes in to the room after the PCP identifies a need there. And so that's the traditional warm handoff. But you could also go into the room before the PCP. We usually call those cold consults. You're going in cold. The PCP hasn't gone in there yet. But your medical assistant maybe has identified something that the patient has told them during the triage process. And so if your PCP is running behind in their schedule, many times we'll jump in before if we already know the patient wants help with tobacco cessation, patient screen positive for alcohol misuse, and they want to talk about that. We can go into the room prior and do our thing, and then give our feedback to the PCP before they go in hopes of having their visit actually be a little bit shorter, because we've done some of that heavy lifting on the behavior change front already for them. This next slide here are just some resources that we always encourage new BHCs. If you don't have these books in your library, please get them. The blue book here, Integrated Behavioral Health and Primary Care, is really focused on assessment and intervention in primary care. There's actually the 3rd edition coming out next year. And so maybe if you want to wait a few more months and buy the 3rd edition that's coming out very soon by Chris Hunter and colleagues. That's a fantastic book on essentially what do you do? How do you treat? How do you function in primary care? The green book is I would consider a primer, psychological treatment of medical patients in integrated primary care. It's almost like a shortened version of the blue book by Chris Hunter. Patty Robinson and Jeff Ryder's book, of course, that's the PCBH Bible, so to speak, of how to just run and start a PCBH service. And then for those of you who are interested in acceptance-based interventions, real behavior change in primary care is fantastic. It builds ACT principles into the primary care setting. And these are interventions that both PCPs and BHCs can do. So again, wonderful resources. If you don't have these books, I'd encourage you to get these, especially if you're new as a new BHC, still trying to figure out, how do I do these interventions that maybe I was taught to do in traditional settings? How do I do them in primary care where the context is a bit different? So with that, I'm going to pause talking and see what questions you all have, again, related to the role of a BHC in primary care, or if you have questions about the BHC certificate course, we're happy to answer those questions as well. So if you want to unmute, you're welcome to. If you prefer to type in the chat box, that is fine as well, and I'll read your questions.
I had a quick question on, you said you're going to be, are you going to email out these slides? There's been a lot of good information. I'd like to make sure do you have our email attached to this?
I believe, Alina, you have them, right?
Yeah, I can answer these questions. So we'll send out a follow-up email at the end of this session, and we'll be sure to attach the slides in there so you have access to them.
Okay, great. Thank you.
Mm-hmm. Do y'all have any questions about the Behavioral Health Consultant Certificate course? Because that is Dr. Obaid's baby, so she will be more than happy to answer any questions that you all have.
And as you're thinking of questions, just to again talk a little bit about the course, 2024 will be our 2nd year of doing this. We've had just a fantastic inaugural year this past year. And I would add that if you're a new BHC or you've been a BHC for many years, the course can definitely fit both across the spectrum. fit both needs. We have BHCs now that are brand new and have been doing this for a number of years. And so if you're wondering, is this, really for folks who have never done this before, or not, we meet needs across the spectrum. So I don't know if that helps clarify things, but I wanted to throw that out there if folks were wondering about that. Well, I have a few other just general resources I wanted to share. So again, if you have questions, throw them in the chat box, but I wanted to share these other resources with you all before we finish today. First and foremost is the Collaborative Family Healthcare Association. Hopefully I'll see some of you there next month. It's in October in Phoenix, Arizona this year. But this, if you've never gone to this conference, it's the main organization that focuses on all things integrated care in the United States. And so it's a great place to network, a great place to understand and learn about best practices in all aspects of integrated care, whether you work in primary care or you work in the emergency room or you work in a GI, clinic, wherever you may work. They cover all facets of the healthcare setting, which is pretty neat. In 2024, we'll actually be hosting the conference in San Antonio, Texas, next year, which is super exciting. And so if you're like, I can't get to Phoenix next month, no worries. You'll just be a quick drive. If you're already in Texas, it'll be easy for you. If you're not in Texas, come anyway. It's going to be great. I promise it won't be super hot, I think, next year. But this is a great organization. So check it out, cfha.net. If you're not a member, but you're a BHC, I would highly, highly, highly encourage you to find like-minded individuals who are doing similar work to what you're doing across the country. Another resource that is fantastic is a video blog called the PCBH Corner. It is run and is developed by Doctors BHC and Bauman out of Washington State. And just about every week, they have fantastic interviews from primary care leaders across the country talking about different aspects of primary care behavioral health, whether if it's policy changes, workforce development, supervision, working with, medical provider, whatever it might be. They cover anything and everything you can think of. They just posted one last week with Dr. Dan Mullen. That was fantastic. I just listened to it yesterday. And so they talk about all things that meet BHCs, PCPs, pharmacists, whatever your role is on the primary care team. It's not just for BHCs to listen to. And it's free. It's just through YouTube. So another great resource that I would highly encourage you to check out. The QR code takes you to their YouTube page. But again, if you're not QR code savvy, that when you get access to the slides, I've hyperlinked the websites on all the pages so you can I'll read them out loud, just in the event people can't see the chat box. So the first question says, can you speak to the balance of educator in gather? I want to encourage our team to do more teach backs to the providers, but given how busy our PCPs are, I realize the point is not that they will utilize these skills. Yeah, I agree with that. And it's getting a sense too, that might not be the best place to do it. I agree. In a busy clinic, I can think of when I'm busy in clinic as a BHC, if someone was coming to me to give me fee, I would honestly stop them and say, I have to go see a patient. Thank you, but catch me when I'm done. I've have like 4 people waiting for warm handoff, so I really got to go. So I agree. If you flip it on that side too, if I'm slammed, that may not be the best way to do it. So I think utilizing time where you have a captive audience, we do a lot of our a formal educator role during our team meetings. We have team meetings once a month with our entire team, nursing staff, PCPs, BHCs, pharmacists, everybody, all 80 plus people are in a room. And so we have a PCBH update is what we call it. And so I kind of go through our reminders of, don't forget warm handoffs. We see everybody. Here's how you put in orders if the BHC is not available. But we go through those things. And then we have a mini didactic every month over a topic that the BHCs have found they've gotten a lot of questions about that month, or providers are confused about something, like, okay, let's do our didactic update about this topic. Or providers just want more information about adult ADHD or helping patients with chronic pain. So it's different topics each month. And so that's our more formal didactic. And it's 10 minutes. It's not a long time. These are short bite-sized pieces. And then it gives us time to have dialogue with the team if they have questions related to that topic. So that's how we do it, the more formal pieces. I've seen some BHC services also do that. I've seen some people send out a monthly email blast. I've seen people use newsletters. I've seen it done many different ways, whatever works best for your team. And then, of course, the informal conversations that happen, after clinic when people are charting or during lunch, those are the informal times where maybe that teach back in the moment could happen then. But I think both and could be really helpful. The informal pieces when it's relevant and it makes sense. And then, of course, the more formal during team meetings where you have a captive audience. So hopefully that helps. If not, let me know. The next question says, is there an advantage of being certified in terms of regulatory audit, in terms of reimbursement? Beth, that's a great question. At this time, there isn't per se, in terms of, I'm assuming you mean if I, do this BHC certificate course. This is more so for the BHC to show that I've been formally trained as a BHC, and here's my certificate to show that I have this, especially in more highly saturated areas that it's a little more competitive for some of the BHC positions, where if I was hiring and I got to decide between someone who had this training and someone who didn't, I will always go to the person who's been trained. And when I talk to my administrative colleagues, many people say the same thing, just because of the time involved to retrain someone who's not been trained in primary care to do the on-the-job training is really time consuming. If you, especially if the health system doesn't have a robust on the job onboarding process, that, typically the more robust ones are 12 to 18 months. And I find a lot of health systems don't do that. They have these quick, you're onboarded in 4 weeks, go for it. And to me, that's just not good enough to help somebody be fully comfortable and competent to function as a BHC. So it's really more so to help clinics who don't have the bandwidth to do that, and also give BHCs the confidence to know how to do this work, so people aren't burning out and leaving because they don't know how to do this work, which is what sometimes we see. So I hope that helps your question, Beth, in terms of the reimbursement. I know CFHA is working towards that, to actually incentivize health systems who have had their BHCs formally trained. I think we're going to get there. We're just not there today, but I know we're moving in that direction. We are trying to get there. So if that helps, I hope so. The last question I see here is, can you speak to the use of the PAC? I like that. The Primary Care Behavioral Health Provider Adherence Questionnaire for measuring fidelity to the PCBH model. I heard about it for the first time today, and I'm eager to hear feedback on the use of it. Yeah, that's a fantastic tool. Those who are not familiar with that tool, you could probably Google it and find it. Greg Beeler, he's a research psychologist with the VA, and his colleagues developed that tool years ago. And it's great especially for if you're a BHC administrator, you lead a team of BHCs. That's something that I would encourage BHC administrators to use, say, during your annual evaluations with BHCs, to make sure that, number one, they know what they're supposed to be doing. Because if you're not doing that consistently, it's very easy to just revert back to the mean. And typically it's not consistent with PCBH practice. And so this tool really helps hold the BHC accountable, but also you as their supervisor, holding you accountable to say, okay, I need to step in and help you with this or this area of practice if they're struggling with that. So that's a great tool. It's evidence-based. It's psychometrically sound. We actually use that in our BHC certificate course to measure change over time as they're going through our training program. And so it's a great tool. There's other tools out there. The BHC competency tool that was developed by Patty Robinson and Jeff Ryder is another great tool that you could also build into your annual evaluations. That's what I use with our BHCs. So yeah, so it's a great tool, and I highly encourage you to think about building that in if you all don't use that. Perfect. Somebody put the link in the chat box for the tool. Fantastic. We have just a few minutes left. You all asked some really fantastic questions. Are there any other questions that people didn't get a chance to ask before we wind down today? Awesome. Well, again, I'm going to hand it back over to Elena to close us out. But again, thank you all for being here during our first